Good afternoon and welcome to United TV. My name is Kamal Erkan. Today is Easter. Well, happy Easter, everyone. So no winter lasts forever. So no spring skips its turn. So I guess every year we are going to have Easter. So happy Easter for those who are celebrating. So our guest today is Melissa Myler-Brown, our state representative. She's going to join me, and Melissa is now joining. And just so that we have it on the record, I'm gonna call her Mimi, and if I'm out of line, you can always ask me to call you Mrs. Brown, right? So how are you doing, first of all?
I am great. Thank you so much. Thanks for having me. And you can call me Mimi. You have permission.
All right, thank you. So we have you once before, last year, I believe. You joined, and you do a lot of health-related bills, and a lot of activities are on the health-related topics. So we want to kind of discuss the issues in Delaware related to healthcare, access to healthcare, and what plans the state has as United Medical being the healthcare provider. So of course, we have a big role in what's being accessed to and how it's being accessed to. So I believe, we have a pretty specific and significant role in that. So if we can start the current state of healthcare in Delaware from the access standpoint.
Can I just say terrible? Does that work? Um, it is though. And you can even look at the HRSA data, right? HRSA, in their report, it shows that Kent and Sussex County are actually a healthcare professional and access shortage area. And Newcastle County is a partial shortage area. So our entire state is suffering right now in regards to healthcare access. So it's something that we really need to hone in on and make a priority and figure out what we're going to do to address it. Obviously we need healthcare providers, right? We're definitely in a shortage there. We were kind of already leaning towards a shortage, and then once COVID hit, it got worse. So we're suffering in that space. I know we have some provider loan repayment or grant programs, and we're doing more around that to make sure that we get more healthcare providers in our states, nurses and doctors, especially to work in some of those areas that really need it the most. But we also need to work with our healthcare organizations and from a bigger standpoint, see how they can also assist with ensuring that we have retention here in our state and with our schools. We need to make sure that our schools are on board, our colleges in our state, University of Delaware, Delaware State. Hopefully we'll have a med school one day, hopefully very soon, because that's really important. And then looking at how we get those providers to actually stay in Delaware once we get them through school here. So go ahead, I'm sorry.
Well, I guess one of the issues, and just so that we were able to discuss briefly what we do from our side. So other than our providers, our physicians, what they do as a direct patient care, from our central office, we have a care coordination team. We have nurses, we have other medical staff who are really helping. And one of the difficulty is to get people on board with what they need to do. People here is patients. So now, I think on one hand, there's the issue of access. On the other hand, understanding that access and what that means to that individual. So I guess that makes a huge difference. So is that something that we can actually take care of, like better educate people to understand what they have access to? Now, access to healthcare, like we always look at, I guess what I'm trying to say is that when we say access to healthcare, like are they able to go to a physician's office or get what they need and all that? But do they even know what they have, especially with the Medicaid population being more than 30% right now in the state of Delaware? So do you think that there's something that can be done for those individuals to better understand what they have?
So I think Delaware needs to really take a large focus on focusing on prevention, right? Because you're absolutely right. What exactly does access to healthcare mean? Does it mean that you may have hypertension and you kind of just live your life with hypertension, and then when you get a really bad headache or you're at the point where you need to go to the ER, you go to the ER? That's not, to me, that is not what should be happening, right? And we see a lot of the super utilization of the ERs, and mainly it's because people are not utilizing the primary care and the preventative measures like they should be.
Mhm.
So it is important that we educate people on prevention, right? On managing their health care, on the importance of seeing your primary care provider as often as needed. Um, and people aren't doing that right now. So it's going to take a lot of community efforts. I know that we're doing some work around community health workers
Mhm.
because they are out there, boots on the ground, talking to people in the community and educating people on just prevention, right? And also connecting them to resources.
Mhm.
And I know that some of the schools are doing this work too. Like at University of Delaware is in conversation to talk about a program for their nursing students, kind of embedding them in the supermarkets, in the libraries, in the pharmacies. And this could be part of their clinical work, but it's just being in the community and just having conversations with people. I tend to do it often. I was actually in I was in a dollar store on Lee Boulevard, and this person was in front of me in line, and he had the whole belt was the canned beef stews, the ramen noodles, just a bunch of canned goods, processed foods, sodas, and I remember saying to this guy, because it looked like he was going grocery shopping. And I said, "Are you grocery shopping?" Just to have a conversation. And he said, "Yeah." And so we ended up talking more. And our conversation went so well that I did find out that this man actually had a diagnosis of hypertension and diabetes. And so we talked a little more. And by the time I was done reading him the nutrition facts on that can of beef stew and then the ramen noodles, he actually didn't buy those items. And I told him, I said, you need to be connected with a cardiologist, you need to be connected with a primary care doctor, and so that you and an endocrinologist so that you can understand the diagnosis that you have and possibly a nutritionist, right? Because he didn't know how to read a nutrition label. And so that right there is a problem when we have someone who has these diagnoses and they don't know that they can manage or how to manage their health care, because that's the person that will end up in the emergency room, whether it's a heart attack, a stroke, or now needing some type of stent placement or whatever. But and if that person is utilizing Medicaid, then that's a big cost driver right there.
So as you were telling me this story, I just want to make sure our audience knows that you are a healthcare provider, right? So you are a so like we don't want people to go out there and then start diagnosing people, which I do once in a while. But you're a nurse
I'm a
practitioner,
nurse. I'm a nurse.
but you did your master's in nursing, right? So I thought
Yeah,
you
so I
were
have a master's in executive leadership.
okay. So
Yes.
well, so you are qualified to make some of those diagnoses. So I just want to make sure that people don't misunderstand. So it would be nice if our representatives they go out there and then start diagnosing people,
I
but
know, right? And
only
so, and for me, I just kind of do an assessment and then just start talking to people because I'm always wanting to educate the community. I've worked in the hospital and I've seen how the ER can be utilized, for so many things that can be managed outside of the hospital.
so one of the terms that we see we actually uh, start implementing early on is the social determinant of health. I think SDOH, we are going to call it shortly. So SDOH is one of the really key factor of understanding how we are delivering the healthcare. Then you can actually look into the access side of it, because what I have seen from different providers, different as we do like different case conferences. So, every day we have our team. So I run one team, and Donna Gunkel, our clinical uh, director, She's running another team. We have 4 people, 4 nurses on each team, 1 social worker, and 1 person from the business development. So the team, as we are going through these patients, like you look at the patient who's actually who's behind with their medication, and then you realize that, okay, well, you call this person and then you find out that they are dealing with a lot of other issues. So it's like they may be taking care of their sick mother who just had surgery, or they may be taking care of their child who needs special attention. And then all of a sudden you realize that it's not just what we are trying to tell them to do, but what's happening in their environment that time, that day, or during that time frame. So then it makes it much easier for me to understand we have to change how we are approaching this. Instead of just asking someone and telling someone, well, you are behind with your medication, or trying to understand why they will be behind. And social workers in that case, they actually bring a really special element to the table where they are able to have some of these discussions in a better way than we do. And then all of a sudden you start understanding there are a lot of other things, not healthcare related, but it's in that person's life. So from the STOA standpoint, how are we doing at the state level?
I actually really love that you talked about social determinants of health. And just being able to take that holistic approach and understanding some like the full aspect of a person's life and just socioeconomics, everything that's involved. So I serve as the chair of the social determinants of health working group under the, now this is for women and children, but it's under the Delaware Healthy Mom and Infant Consortium. And we're actually coming up on the very end of a 2-year pilot that we started 2 years ago. I sat with my group when I first became the chair, and I said, we need to come up with some priorities so that we can get something done that's tangible and actually has an impact on Delaware. And we came up with a bunch of priorities, but the number one was housing. So because the group said, well, we don't have stable housing, how can you really manage any of these other aspects in your life? So we came up with a pilot program for 40 women. It was 40 pregnant, housing unstable women. And in this program, we offered these women housing, access to the OBGYN, of course, because they were pregnant, behavioral health resources, because these women were housing unstable and most of them didn't have employment. And we wanted to make sure that by the end of this 2-year pilot, we were able to get them to a point of stability, because it is possible. Education, financial literacy, and a $1,000 stipend every month. We also gave them a $1,000 stipend on top of whatever they already had financially. And case managers and community health workers. And so we followed these women for 2 years. And it just shows how when you offer a hand up and you really wrap your arms around someone and understand what they're going through in their life, every dynamic, and you can really get them to a point of stability. And we talk about like maternal health and maternal mortality. We didn't experience any of those complications with these women during this time. And we actually saw a 324% return on investment by the end of this pilot. These women are employed, they've had their babies, they are housed, they are stable, some are in school, some have completed a program like a phlebotomy program, one is in a program to be a nursing assistant, but all of these women have successfully gotten through this pilot. And they are in such a better space than they were when they came in. And to just see that by putting all of those aspects in place, and you talk about that full scope, that care model, you can actually get someone to a point where they can sustain and be okay and manage. So that's something I wouldn't say on the state level. Well, we did it for a reason. We did this pilot for a reason, because we had to show how we can move the needle to actually lift someone up out of poverty, get them to a point of stability, get them to a point where they can manage their own health care and maintain employment. And we needed to have that data to show that it really works when you, like you said before, take that holistic approach to address the social determinants that exist. You need housing, you need healthcare, you need education. Those are the three main things right there.
It's
And,
the whole, it's the whole picture. It's not just one, one element of those three. Like when you mentioned housing, I couldn't help but think about there's a group of patients we have that I never knew until we started doing the case conferences. These people are homeless.
Hmm.
I have almost 35. Sean actually is in the room earlier, so we were kind of our start was a little bit not our normal start. So I was going to introduce him, but maybe we'll do that then. So when we look at our patients, as we are trying to get them, like, why are you going to the ED, like the hospital, rather than just calling or coming to the primary care's office? Well, then you find out the patient is homeless.
Yeah.
Then again, the social worker side of our team, they're actually doing a really good job with those. But I wouldn't think that we had homeless patients who have insurances. So like that's why maybe from the access standpoint, when those, especially in like one thing is like in Delaware, Medicaid is one of the probably best programs in the country in terms of insurances. So,
Mhm.
I'm more on the independent side. I do criticize both parties a lot, publicly and off screen. So, but from the Medicaid standpoint, the program that we have for a long time is one of the best programs in the country. Now, the challenge is that population is increasing, and can we actually keep doing what we are doing today with all those new people adding into the system? That's a challenge. But then I was thinking, like, they instead of just being eligible for this insurance as Medicaid, they really need to, we need to get them from that level, like at the signing level on the enrollment level, so then they can actually start being managed instead of waiting until they get in trouble and then try to look for some care from, like, because they have primary care assigned to them and they don't know they have a primary care. Again, the person is homeless. So, and then I'm calling the person, just imagine like how kind of like not so smart what we are doing in some cases. I'm calling the patient and saying that, like one of our nurses calling, hey, well, you go to the ER a lot, so we need to, control that, and then you need to start coming. And the guy is homeless, so that stops everything right there. So that it becomes like a meaningless conversation unless we have those professionals like social workers. They come into the picture, and then they start helping uh, and showing them different resources that we have statewide,
Mhm.
because they better understand and they know those better. But there is a huge, I think still there's a huge gap on the social determinant of health from practices to practice, from patient to patient. They really don't maybe understand, these programs that we do, we have, as you know, we have this at 2 p.m. and then I have 3 p.m. Bariatric Friday with Dr. Ergal, one of our surgeons. And the goal is not to just help those who are going through the program, but people who are dealing with any type of like on the weight loss issues, morbid obesity, and then we are providing a lot of education out there. How many people we are able to reach? That's that's a question, but I think we have to keep trying. So from I'm gonna switch gears to the telemedicine. Now, I do ask these questions directly, and then we didn't actually tell you what we were going to ask you. It was just the healthcare was a topic, and because we are also friends, so I don't want to actually corner you too much. But I am gonna I'm gonna put you on the spot. So, is telemedicine staying for long term? So, is it our goal from the state level that we are going to keep telemedicine after we are done with the pandemic related issues?
Yes.
Okay.
How do you feel about that?
How do I feel about it?
Yeah.
I feel good about it because Telemedicine is a huge tool. With pandemic, it was a huge crisis for us. But I try to see some silver lining in any type of trouble that we go through. And one of the silver lining in that is overnight we start using telemedicine. So people, physicians, and patients who didn't want to use telemedicine, it was like magic overnight. Everyone knew what to do, and everyone knew how to access to their cameras and this and that. In 1 week, we were like 95% telemedicine. So now, of course, unless we see some of our patients in person, telemedicine is not the replacement of actual visits. I, in fact, wrote an article when telemedicine started, and once we start kind of settling, there has to be certain standards. So, because we don't want patients or physician offices to take advantage of what's available to us, so we don't want to compromise quality. So you asked me from the come, I feel good about it, but I also feel like there has to be some set standards so that we are able to keep the quality, so that it doesn't become like, oh, it's being taken advantage of, and then we are going to shut down telemedicine. Because I don't know if your parents, are they with you?
Yes.
So I have to be careful. So my parents are 73 and 83. I don't want them to go to a physician's office in the middle of the flu season.
Right.
It is something that can be done through telemedicine.
Right.
But there are times that we have to be in those offices, and that's how we can actually make those differences. And in many cases, like for our dietitians, they do telemedicine, and that can be done 100% telemedicine. There's not necessarily you have to see them because you don't need to examine the patients. Some specialties, it's a perfect fit, and it's a great tool to eliminate some of those compliance issues too. Because with the chronic patients, so they need to be seen 4 or 5 times a year in some cases, but not all of them have to be in person. So because of that, I think telemedicine is really important. It should stay, but with some set standards, so then we don't go down on quality.
I agree 100%. I think about when I have my telemedicine appointments and, I get the phone call first from the medical assistant and they're like, well, have you checked your blood pressure? What is it? But I have, but I think about people who really don't have access to those items, right? And they don't know what's going on. So I think it is convenient in some aspects, but you're right. There are times when I'm like, I want to go into the office, I want to be touched by the doctor's hands. I need you to feel my lymph nodes. I need you to make sure I'm okay. And then there's times when we can have this video visit and it's just kind of like a check-in. This is what's going on.
And I think this is where the state comes in. I mean, I don't want government to be in our business all the time, but there is an absolute necessity when it comes to healthcare and having those standards, because everyone has different understandings. They do however they understand, and that becomes a problem. So, this is not just one-sided. Like we had some patients when telemedicine was available from the beginning. So like we used to get calls, videos from like patient was in the ShopRite, they were in Acme, they were driving. So we are like, hold on a minute. This is not about just having, video call with you. You need to be in a setting where we can actually talk to you. You can actually tell us what's happening. It needs to be private and all that stuff. And that's why I actually wrote an article, because I was having issues, one on the patient care side with the interactions, one on the business side too, even with the, we stopped having all those in-person calls, in-person meetings, and now we are doing tele meetings, but then people don't turn their cameras on.
Yeah.
I'm like, well, at some point we start losing that connection because when there's a lot of benefit of having certain things in person, but then now the alternative becomes like no camera is just like a phone call type of meeting. It's not the same effective meeting anymore. So I actually started having um, little fight with some of the vendors who are not turning
Yeah.
our camera's always on. So like if it's a telemedicine or telehealth or telemeeting, business meeting, your camera needs to be on. So then we can see each other. We still have eye contact. I still know what you are doing if you are listening or not, right? So it would be like we don't want to compromise the quality, not just for healthcare, but also from the business side too. It's like that's why I have to put this the ethics or the etiquette of digital health at that time.
Mhm.
So it's like 3-4 years now. But telemedicine at the end of the day should stay. Um, now, what are the latest bills that you are working on, healthcare related ones?
Ooh, let me think. What am I working on? I feel like there's so much going on. Every time I say I'm going to take a step back, I can't because something comes up and it needs to be fixed or addressed.
So you had
Well,
one with colorectal cancer screening. I can help you a little bit.
yeah.
So you had one with colorectal cancer screening. Well, Sean is helping us there. Thank you, Sean. So that's
Oh, yeah, that's important. Yep. You
you.
need to educate folks.
Were you the co-sponsor for that?
So yeah, let me see. Is that for? Yes, I believe I was the house sponsor or the house. Yeah, for colorectal cancer.
Mm-hmm. And
I
then you
believe so. I don't even remember. There's so much. Oh, and then kidney month. That's
had
another one.
kidney month.
Uh-huh.
So then,
Oh, I'm a co-sponsor on Griffith's bill too, House Bill 340
right.
for the Family Justice
What about
Center.
the primary care bill?
Which one?
The is it or is it the Senate bill?
I got to think of which one
One
you're
with
talking about.
Brian, actually, that's the Senate bill. Brian
Might
Townsend.
be Brian Townsend. Yeah, yeah, yeah. Okay. So yeah, so I just expanded some doula coverage for
Mhm.
because we did the Medicaid reimbursement for doula care, but then we realized that sometimes women need additional support. Actually women and men, beyond the beyond delivery. So we wanted to make sure that we would allow for additional visits for doula services beyond that point. We are doing some expansion
Mhm.
for women's reproductive health services so that abortions are covered through Medicaid and private insurance. What else are we doing? Let me think. Let me think. Let's see. I'm working on some legislation for preceptors to receive reimbursement somehow because we have to improve the workforce. And so, in order to get these students precepted, these APRN students, these physician assistant students,
Mhm.
we understand that because we're in a workforce shortage, that you're already spread very thin, and I think that a little bit of reimbursement could probably go a long way. Um, what else are we doing? It's so funny. I should have came here with a list of things I'm working on because I don't even know.
So now, from the community health initiatives, are there certain partnerships that the state of Delaware is doing with the communities right now?
Hmm. I'm sure there are, but I don't know what that is right now.
Okay, so like I think that's something that we want. Maybe one of the issues with us from United Medical ACO side, because we are labeled as for-profit organizations, although we take care of the same patients that those not-for-profit organizations do.
Mhm,
In fact, in some cases, some of them can be part of the hospital systems, which can
mhm,
be even more expensive to the taxpayers. Unfortunately, when it comes to those community health initiatives, in some cases, those organizations like us are not the first on the list. We have about 115,000 patients on primary care level.
mhm,
There are about 500,000 appointments just in Delaware every year that we go
mhm,
through. And that's a huge access. from the starting any type of initiatives with the public. So we want to do more, but I think this for-profit, not-for-profit becomes a problem. Maybe that would be a follow-up with you and with your team, that we can actually look into that in a different way, because we are right now number one Medicare ACO in the state of Delaware out of 4. These are public. Number 17 in the nation. So this is kind of like, this is one of the handicaps that we feel like every time there's something happening with the state partnership, they're like, well, you are not a, you are a for-profit organization. Now, one other thing with the access that's important is physician shortage. As we have a physician shortage, we have nurse practitioners and physician assistants are coming into the picture. But are there, and we have a J1 Conrad program in Delaware for a long time. For those who may not know, that program is whenever we have this shortage, physician shortage, we are able to have a physician who's foreign graduate, and then they have to serve there for 3 years. So how do you actually see the physician shortage as an access issue for the future? Like coming up in, in the next 10 years, this is going to become a bigger problem. Do you think anything can be done at the state level to help the shortage?
Yeah, I think, and so this takes me right back to where I think everyone really needs to be at the round table. I think we need to have our providers at the table. I think we need to have our schools at the table. I think we need to have our hospital systems at the table. And we need to talk about what we can do to support this effort, because you're right. We're already in a shortage. And right now, if you can't even get an appointment, right? Like it might be a month or so out, and that's not good.
Yeah.
But I go right back to what kind of incentives can we provide to keep people here? Because that's like, I talked to an MD and we talked about living downstate, right? And it's expensive to live down by the beach. But that's where, with that, according to the HRSA data, Sussex County is in crisis right now. We need providers there. So how do we get providers here, and how do we keep them here? What does that incentive look like? I was looking at some things that were done in other states, and I saw where there were hospitals that would provide a stipend to primary doctors who would come in and work, and they would provide a stipend for a year for their housing, but they had to owe back a certain amount of years. I've seen a lot happen where the systems can come in and help to improve, and the schools too can come in and help to improve the workforce. So, and the state as well. I mean, it could be a collaborative effort, but I think we shouldn't make a decision without having you all at the table so that we know what the path forward will be. I'm here as a legislator. I don't have the answer, but I'm hoping, and that's why what you just said before you asked this question, you said, we want to be at the table. We want to help. We're doing all this work, and we want to partner. I think that's where we start. We start with having these conversations, because what I'm going to say to you when next time you come visit me, I'm going to say, how can I help you? What do we need to do to improve the workforce here in Delaware? And you need to tell me. I'll get it done, but I need to know.
Right. That's actually, absolutely. That's one of the reasons that we are having these types of dialogues. Again, another silver lining of the pandemic. If we didn't have a pandemic, we probably wouldn't have this type of a show on a weekly basis. So, like last Monday when I saw you, we look at the room, and then at least 15, 16 of the individuals who were on the show. And that, increasing the awareness of what's going on and what's happening, and from right from the field. So these are the issues. But I think from the physician shortage, what surprises me a little bit is University of Delaware is one of the best colleges in United States, and I think their also health care program, their nursing program is really excellent. I think there's a lot of potentials that we should have a medical school with the partnership with UD, but I don't know if maybe there's someone already working on it and no one told us that. I don't know, but one of the other goals for us is we want to bring the president of UD and then discuss certain things, and then maybe we'll ask him. Is it he or she right now, Sean?
Dr. Dennis Asanis. So
Right. So we'll ask him to see if there's anything going on. Now, so you are not up for an election this year, so
yes, I'm up every 2 years.
Stress-free year for you. So, but a lot of
It's never a stress-free year.
so now, do you want to make any prediction for the state level? So who's going to be our next governor?
Oh, Bethany.
All right. So who's going to be our lieutenant governor?
I don't know. There's three amazing women running.
Mm-hmm.
So I don't know. I have in my mind who I think is going to be the next lieutenant governor, but I'm going to keep that quiet.
So I guess we know who the next I'm going to say who the next congresswoman is going to be, right? So Sarah is going to be that person.
That's what I'm hearing. But
Fine.
we've got another candidate. Eugene Young is running also, but it sounds like Sarah is.
Young, he's a really good guy. I like him a lot. He was on our show, and I think he's putting a lot of effort now, a little bit more than what he did in the start. But I think Sarah Sarah is the brand name in politics these days, so it's tough to beat her. But not because Eugene is not, qualified.
I know exactly what you're saying.
Yeah, right. So like, I wouldn't want to run against Sarah in any of these races.
Me either.
So Lisa Rochester was with us last Thursday. So she's gonna be our next senator. So it's gonna be an interesting one. But what about at the president level? So you're a healthcare. So I shouldn't be doing this to you, but I'm going to do it anyway. So you're a healthcare provider. You're a nurse. You diagnose people while you're shopping. So do you think Joe Biden can run for another 4 years?
Yes.
So
I feel like I just gave you a politically correct answer.
so I don't know. I'm just worried about him. So hopefully he's doing okay health-wise. So anything you would like to add before we close the session?
I think we had some really good conversation today, a really good dialogue. What I am going to ask is that after we finish up here, we set up a date to get together and talk about how we can work together to improve access through, just doing this work, boots on the ground in the community. You said a lot of good things. And one thing you said was that your organization is not typically at the top of the priority list. And I know the work that you all are doing. So I would love to talk about that. And I also want to I want you to bring to the table some of your thoughts and suggestions around how to improve the workforce as well.
Absolutely. So we'll be following up with you. Anthony Anubu is one of our directors here. He works on the contracting issues with me. Sean also works with me in these for this program. So we'll definitely have a follow-up with you, and we have a couple other items that we work with Brian Townsend anyway. So it would be great to bring certain issues directly to you and see what we can do. Well, thank you so much. And I know this was kind of a short notice for you and that you were available today.
Okay.
We really appreciate these participations, and we'll see you soon.
Yes. Thank you for having me. Have a great weekend. Bye.
All right. Well, Sean, you want to join?
Yes.
So then people know that I'm not lying. You're here.
I'm here.
So, good conversation.
Yeah. I think one of the things that you kind of just touched right there at the end, but the willingness for her to join on such a short notice. So we did run into her Monday night at Valerie Longhurst campaign event, And just by, bumping into her and bringing up the fact that she was on previous sessions, would love to have her back. Literally, you can attest to it, took out her phone, looked at her calendar, said she had the opening to be able to do it,
Right.
just like that. Simple and as willing, wasn't, oh, I'll have to get back to you, or let me get you in touch with my secretary or assistant, and they'll reach out. And of course, the willingness I thought really stood out.
True.
For that.
No, she has a lot of energy, and like with the nurse background,
Mhm.
Understanding the healthcare, it's really important for individuals to really know what's happening from the provider standpoint. So I think she can do a lot of good stuff for the state of Delaware.
Mhm.
All right, so we have our Bariatric Friday in 15 minutes. Next week we have Robert Puccini.
Robert Puccini, he'll be joining us, and then we also have Governor Carney in the middle of April,
Mhm.
the 19th.
And Valerie Longhurst.
Potentially on the 12th, waiting for the
Yeah,
confirmation.
12th or the 26th. So we'll have more coming up. So, all right. Well, this Sunday is Easter. So
Yes, today's Good
happy
Friday.
Easter.
Happy Easter Sunday coming up.
So we'll be back with the Bariatric Friday. There's a Good Friday, there's a Bariatric Friday. So then we'll be back with Bariatric Friday in 15 minutes. Thank you for watching us.